Hi everyone, let's quickly talk about what exactly is spinal tap. Spinal tap is also known as lumbar puncture, and in easy words, if anyone asks you what exactly is spinal tap or lumbar puncture, in this basically we withdraw a sample of cerebrospinal fluid. So you need to withdraw a sample of CSF. This is, in short words, this is what exactly spinal tap is, right? And why do you need the CSF? You need it either for microscopic or bacteriologic examination in order to, for example, find out if the CSF has some sort of bacteria that causes meningitis or any other diseases. So you need to, for diagnosis purposes, you're going to use it for microscopic or bacteriologic examination, or you can use the CSF sample. I mean, you could either use this technique in order to inject drugs into the cerebrospinal fluid, right? And other than that, this is also used for the induction of anesthesia. So, what are the three main reasons you're using spinal tap? Either for microscopic examination, or to inject drugs, or in order to induce anesthesia, right? Now, there's few terms that you need to be familiar with. The first and foremost is conus medullaris. This is conus medullaris. This is basically the point where your spinal cord terminates. So this is your spinal cord and it terminates. So its termination point is more of a cone shaped. So this cone is basically conus medullaris, right? I hope this is understandable. And then you need to be familiar with the term phylum terminale. Phylum terminale is basically an extension of pia mater. Pia mater is basically the innermost layer of the meninges. So an extension of pia mater, it extends from the conus medullaris and it anchors the spinal cord to the coccyx and holds it in a stable position. So this is phylum terminale or phylum terminale. And then there is cauda equina. Cauda equina is basically, now if you know about the spinal cord, so there'll be a spinal nerve which will be coming from corresponding segment of the spinal cord, right? And each of that spinal nerve is going to pass beneath the vertebrae or maybe sometimes even in some cases above the vertebrae. But beyond L1, in the lower border of L1, basically what happens is that the spinal cord terminates in adults, and in babies it terminates at the level of L3. So beyond L1 vertebrae level, all the spinal nerves they all bundle up together and they form cauda equina, which is known as horse's tail. So I hope that makes sense. So L1 is where you have conus medullaris right here. I hope you can make that out. So conus medullaris, cone-shaped end of the spinal cord, around L1 to L2 vertebral level in the adults. Phylum terminal, phylum means thread, thin fibrous thread. It's a delicate extension of pia mater from the conus medullaris. It anchors the spinal cord to the coccyx, stabilizing it. Cauda it's Latin for horse's tail, so it's basically a bundle of lumbar, sacral, and coccygeal nerve roots which descend below the conus medullaris. So yes, conus medullaris, end of spinal cord. Cone shaped, phylum terminal, fibrous thread from cone, thin cord shape, and this is extension of pia mater. Then cauda bundle of spinal nerve roots, horsetail like. I hope this is clear, right? Now, other than that, cauda equina. So cauda equina it consists of what all nerves? This is also something you need to know. This is extra information, but I'm still giving it to you. It has lumbar nerves, sacral nerves, and coccygeal nerves. And there could be a possible cauda equina syndrome if there is any sort of destruction, damage, or pressing of all of these horse's tail, cauda equina, all of these nerves. It can result in back pain, saddle anesthesia, bladder or lower or bowel dysfunction or weakness in legs. Now, talking about lumbar puncture or spinal tap, so the person he should be lying sideways or he or she could be sitting upright, right? And this position of lying sideways is known as the recumbent position. This is the recumbent position. So the patient is going to be lying like that. Now, what you need to do is basically you need to inject the needle with the help of a stylet. Stylet is basically a probe that is going to direct the needle and below the level of the L1 vertebrae. Below that, you have to inject somewhere. Now, the point of this is that you have subarachnoid space here. So, thankfully, the needle will be injected in the subarachnoid space, and you have to ensure that you do not puncture the spinal cord because that will be dangerous. So, you have to insert it below the level of L1, right? So into the subarachnoid space, and from there, you're going to withdraw the sample of CSF, and that will be used either for bacteriologic or microscopic examination, or in order to inject drugs or for inducing anesthesia. So here you can see the patient will be lying on his side or sitting upright position, and an imaginary line is there which joins the highest point on iliac crest. It passes over the fourth lumbar spine. So if you touch both of your iliac crests, you'll realize that yeah, this is the position of fourth lumbar spine. So that's the easiest way to point out that yeah, this is the safe space where you can inject the needed. Now, also another reason for making the patient lie in a recumbent position or upright, in that way your vertebrae will be flexed and the space between the adjoining laminae of the vertebrae in the lumbar region will be maximum, and this way, like this. So in this way you can easily inject the needle, and once the needle is injected, it passes through the skin, then superficial fascia, then through the supraspinous ligament right here, then the interspinous ligament right here, then the ligamentum flava, and then the internal vertebral veins, right? So these are all the regions it crosses, and then finally dura mater and arachnoid matter. So this is what you need to reach. And sometimes what happens is that you're going to notice a few drops of blood. This means that you still need to ensure that it still goes further, because right now it has reached the layer of internal vertebral plexus. That's the reason you're withdrawing blood. So you need to still press it more so that it reaches the subarachnoid space, right? And sometimes if you are touching any sort of nerve roots, so there'll be certain regions, dermatomes or muscles that will twitch, or they'll feel a fleeting sensation. Now, the normal CSF pressure is 60 to 150 millimeter mercury. And how do you measure that? You measure that with the help of a manometer. So you need to attach the manometer to the needle, and this way you'll be able to keep a close track of the pressure. Now, pressure is going to show oscillations which correspond with the respiration and arterial pulse. So basically the movements of respiration and arterial pulse, sorry. Now, there's a very important thing which is known as Queckenstead sign. Now, what happens is, normally, if this is your arterial pressure, so if you touch your internal jugular vein, if you press the patient's internal jugular vein, both on right and left side, what will happen, obviously now there's no way for the CSF to go and drain in the arachnoid granulations, and what will happen, that CSF pressure will increase when you press the internal jugular veins. Normally it should increase, but in case of positive Queckenstead sign, the pressure doesn't increase. Why? Because there's already some block present, either because of the tumor of the spinal cord or the meninges, or because of any other reason. There's blockage in the subarachnoid space. So you pressing the internal jugular veins, it's having no effect, or no, it's not making a difference. So positive Queckenstead sign is a very strong indication of presence, a potential presence of tumor of the spinal cord or meninges. In simple words, if you want to know what is Queckenstead sign, so Queckenstead sign is a clinical test which is used to detect the blockage of spinal subarachnoid space during a lumbar puncture. Normally, when the jugular veins in the neck are compressed, intracranial pressure rises, and this quickly increases the CSF pressure in the lumbar region. So you have to perform lumbar puncture and measure CSF. Then you have to compress both the jugular veins, and you're gonna notice that the CSF is going to rapidly rise, and then once you release the compression, when you decompress it, the pressure will be released as well. But in positive Queckenstead sign happens when there is blockage, right? There'll be no rise, or there'll be delayed rise, because already there is blockage. So you pressing the internal jugular vein is making no difference, no big of a difference. So it indicates blockage in the spinal cord because CSF pressure is not rising. So causes of blockage could be a potential spinal tumor, herniated intervertebral disc, spinal cord compression, tuberculosis, meningitis, and yes. So if CSF pathway are open, pressure is going to rise quickly. But in the Queckenstead sign positive, there is going to be a block, and pressure is not going to change. So jugular compression increases pressure in brain, but if the CSF pathway is blocked in the spinal cord, that pressure cannot reach the lumbar CSF, so no pressure rise is seen. So I hope this is very simple. If you read that, you'll understand. So that's basically the summary. So I hope you understood what spinal puncture, spinal tap, or lumbar puncture is in simple words.